Welcome friends, colleagues, and dear students on MuniMeter Health, your source of learning about cardiology and human heart. This is Dr. Jaitly from New York. Welcome again on MuniMeter Health. Very briefly, we're going to be talking today on this video, what are the diagnostic evaluations in a setting of heart failure that one entails. Now, remember, all these tests that I've enumerated here by the asterisk does not necessarily imply that all these tests will have to be done one after another. However, certain tests will be guided based on your suspicions, certain tests will be guided based on what you can really treat, and certain tests will be guided by your clinical acumen, where you suspect that maybe there's an etiology that you want to really ascertain, or the cause you want to ascertain, and perhaps also be guided by the therapeutic options that you may be left. So let's understand first, very briefly, we're going to talk about BNP levels. Now, BNP levels normally should be less than 250, but in a patient who is less than, say, 50 years of age, okay, so the levels may levels imply that they should have levels which may be more than 500 in those settings. Nanograms, remember, these are nanograms per ml. Okay, now more than 50 years of age, like in middle age to an elderly person, there the limit is about 950 and above. So you should have 950 above, which will be diagnostic of a exacerbation of heart failure. Quickly, a chest x-ray, of course, will show curly B lines. We know that, so we can write that here. Curly B lines are very specific. They are showing interstitial edema, if you will. I'll write it down like that. And of course, the cardiomegaly will be present. So the core size or the heart size will be enlarged in these settings. Okay. ECG may show sinus tachycardia, but may also show atrial fibrillation, and may show SVTs, and of course a lot of VPCs, but there might be just tachycardia itself alone. Now, echocardiography is the mainstay of all diagnostic as well as prognostic and therapeutic options. Remember, echo is a wonderful test. It's a non-invasive test. It's a sonogram of the heart. Basically, it's done in 2D, and a 2D echo itself really provides a great deal of information. So let's understand what it tells you. Well, I'll draw a sketch here quickly to show what the echo looks like when you're doing a two-dimensional echo. Now, here is your aorta. This becomes, of course, your septum here, which is separating the right ventricle, which is sitting on the top, anteriorly rather. And then you have your mitral valve, which is your anterior mitral valve leaflet. The posterior mitral valve leaflet comes here, which continues with the posterior wall of the left atrium. And there, right at this junction, you'll have the left ventricle coming out like this. So this is your left ventricle, the posterior wall. This becomes your apex, and obviously this is your base, this is your anterior, and this is your posterior. So this is the classic long axis view like I've shown you on the right side panel on a 2D echo, okay, if you will. So this is your RV, and this is your LV, this is your LA, this is your aorta. So the blood is actually flowing around in this direction. We'll show it with a slightly different color here. Blood is going in this direction. How? So from left atrium to left ventricle, when the left ventricle squeezes, the blood goes out into the aorta. Okay? And the right ventricle, of course, we are not concerned right now. We're just concerned about that. So on an echo, one follows the ejection fraction. So it's very important you need to follow the ejection fraction. It should be, obviously, normal should be more than 55%. We know that, 50 to 55%. Anything less than 50 is considered as borderline, but when you go to 40% or so, that is called, less than 40 is considered as heart failure with reduced EF. We call it HFrEF. Anything between and then there is another condition called where the EF could be 45 or 50 or closer to 50. Then you will see that's called heart failure with preserved EF. Okay, so HFpEF and HFrEF. Okay, so we have done that on a different video. So just so that you know, and the EFs need to be serially followed. So we tend to follow them serially, the EFs. So that's why we precisely do an echo. And prognostically, it's very helpful because one, it'll guide you whether the therapy is working, and two, whether the condition is worsening, also whether you should really apply other treatment modalities, which we'll discuss on a different video lecture. Okay, now coming back to the cardiac MR. Now, it's reasonable to perform a cardiac MRI in a setting. Remember, it's an expensive test, but it'll only help when you're suspecting some infiltrative diseases, like sarcoid, for instance. If you suspect that. But normally sarcoid is diagnosed clinically itself. You'll have nodules in the lungs, on the chest x-ray. There might be a quime test which may be positive on the skin. Your ACE levels may be high in that individual, and of course, like I said, there'll be lung nodules. Okay, so clinically sarcoid could be diagnosed, or there is a history as well. And many of these patients also have keloid formation, like they will give you a history of trauma or surgery, and at that point the scars heal with a keloid formation. So a lot of patients will have that as well. So having said that, so infiltrative diseases, the next one will be, which is very commonly seen, is amyloid. Now, amyloid is diagnosed on an echo by seeing scintillations. So one sees a lot of scintillations, if I can draw in this little diagrammatic place here. You could see a lot of scintillations within the left ventricular wall, and they're very shiny scintillations, and you cannot miss that, and that is classic. And so these scintillations, scintillating echo myocardial shadows, or on a long axis, or even on a 4-chamber apical, will be diagnostic of amyloid. But you could do a cardiac MRI, which will also define that. People have done biopsies as well. So let's do the endomyocardial biopsies for a second here, and one can diagnose these infiltrative conditions, but provided the therapy is going to change. Normally endomyocardial biopsies, it's reasonable to perform if the therapy is going to change. Remember, it's an invasive test. It is not free of total danger, and therefore it causes a lot of other problems. So you have to be very careful. MUGA scans are normally done only to assess the EFs, provided the echo is insufficient or technically difficult. So whenever the echo is, I call it TDS, technically difficult study, and then you would do an ejection fraction via a MUGA scan. It's called the gated blood pool scan, and that's done by nuclear left ventriculography, also called as. So it's by injecting a technetium scan isotope and tagging it to the red cells, and one can assess the left ventricle and assess basically the contractility of the left ventricle in systole. This is your, say, systole, and then in diastole, where the heart is about this big. Obviously in diastole it will be like this. So the subtraction is done where the LVEDV, which is your left ventricular end diastolic volume, is subtracted from left ventricular S systolic volume, and that gives you the stroke volume. Now the stroke volume, if you were to look at the ratio of the stroke volume over LVEDV, that will give you the ejection fraction. Okay, so just remember, ejection fraction is always expressed as percentage or sometimes as a ratio, but normally, as I said, more than 50% or 55% for our sake for discussion is considered as normal. Now, coronary angiogram is an invasive test, again not totally free of risk, but it's normally maintained to do this when you're suspecting ischemic heart disease, or specifically so ischemic cardiomyopathies where the ventricle is dilated and there is some evidence of ischemia, and maybe perhaps you can offer a bypass. You can do a CABG in these individuals, or you can actually end up giving them PCIs or stents, if you call. Okay, and they have been discussed extensively in my other video lectures. Now, endomyocardial biopsies we have already discussed, where only where a tissue is obtained. Sometimes you may also obtain a biopsy for your own research values, and where you really want to know what is the kind of myocarditis which led to endomyocardial problems. Like specifically, so if you wanted to know the incidence of echovirus or Coxsackie virus, or even the HIV, has that been affecting, or Chagas disease, that could be diagnosed based on endomyocardial biopsies. And then you could also, people have done, or many scientific groups have done actually for toxic agents, specifically after applying the various chemotherapy agents like adriamycin or Cytoxan, when these patients have cancer and these drugs are used. And obviously these are toxic, cardiotoxic agents, as long as one can really use them very carefully. And there are certain cutoffs that you have to apply in order to make sure that these patients do not suffer from cardiac disease while you're actually treating the cancer disease. So endomyocardial biopsies there will be indicated. Okay, pulmonary artery catheters, which are Swan-Ganz, which are formerly, or long, my generation will definitely call them Swan-Ganz. Pulmonary arterial catheterizations, these are flotation catheters. They're classically done when patients are either markedly hypotensive, where the blood pressures are extremely low, Renal functions are deteriorating, so you have kidney functions, KFTs, deteriorating, or sometimes patients are not responding to even IV therapy, including IV inotropes. So wherever you have inotropes being used, specifically when these patients are shocky, in a cardiogenic shock, etc. So pulmonary arterial catheters will have a huge role, and it's reasonable to place a catheter in that. Also, patients who are going intraoperatively and waiting to bridge, if you will, and bridge onto a cardiac transplant list. Say patients who are markedly sick, obviously they are in cardiogenic shock or in decompensated heart failure, and they're on positive inotropes, while they're waiting on a bridge, and they're waiting to, and they're waitlisted on a cardiac transplant, pulmonary arterial catheter may be used very reasonably in that setting. Viability is another test which is done nuclear, by nuclear means, and basically nuclear implying that you use technetium-99 or thallium-201. Thallium-201 is more preferable because that'll give you the redistribution and speaks of viable tissue, where wherever there is viability, automatically thallium will return back. It's called redistribution. So one sees a segment, say if we can use a different color here, say one sees a segment which is viable here in the inferior wall, and that is not commonly seen when you're actually doing a regular testing or other testing. Then you know that this area is viable. But if it is non-viable, none of the area is viable, then actually that makes a case for cardiac transplant, because this you cannot bypass. Inferior wall is now supplied by RCA, we know that. So if the inferior wall is supplied by the RCA and you know there was ischemia as a result, there was viability here, one can actually go ahead and bypass clear, revascularize, rather, that's the right word, revascularize the RCA. Or similarly, say if there's a septal wall involvement, etc., and one has viability here in question, then you could actually open up the LAD and revascularize the LAD by bypass or stent, whatever is feasible at the time. But the fact is that if it is non-viable and the heart failure is present, then those individuals, or the FDG uptake is not there. So remember, FDG uptake, whenever it is positive, it implies viability. So FDG, remember, glucose will only goes to the place where, just remember for the test sake, for the exam sake, glucose will only go wherever there is viability. So this is 5 fluorine tagged dextroglucose using a PET study where one actually assesses the viability. Again, the details are on other video lectures, but just so that you know, all these testings are very, very helpful provided you use them judiciously. Again, idea is not to use all these testings in a row, but you could apply certain testings based on what you suspect and how you want to treat these patients of heart failure. Okay, so just a short, quick lecture. I know it's very, very compact, and the fact is that it's information studied for you so that you can quickly grasp right before you take the exam or the test. And I will appreciate if you press the like button if you liked it, obviously, and put questions and give suggestions, and if you have any comments, please do not hesitate to write back, and I'll make it a point to answer that within 24 hours as soon as possible. Okay, and now let's meet again on the next video lecture. This